Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. I've decided to group 16 short earwax removal procedures into one video for your viewing delight. And this is patient one. Patient one attended with medial impacted dry sticky wax. I think they've been using a Q-tip because you can see the indentation on the surface of the wax and it is quite lodged. So some of these videos are quite old, so I can't be sure of their exact case history. So I'm just using microsuction here, just trying to leverage this through, and I'm going to the top of the ear canal here. It's where I can get a better suction grip, and I'm slowly but surely just teasing this through. You can see it looks a bit like a bird's nest. There's a few matted hairs, which is another sign that a Q-tip has been used to try and clean this wax, but instead it's just further impacted it into the ear. So we're right near the entrance, so the fact that we can see those hairs there, they are typically located on the first bend of the ear canal, which is about 1/2 centimetre in. So it's on the cartilage portion. So we're nearly there. Because the ear canal isn't straight, there's bends and twists, and then there's widenings and narrowings. If the wax plug is quite large, not only do we sometimes have to bring it through a narrow section of the ear canal, but we also have to mediate the bends. And that's what we're just doing here. I mean, I could just probably use an ear hook at this stage, but by the time I get the ear hook, put the suction probe down, get the ear hook out, go into the ear, probably been the same time or quicker with suction. So because we're nearly there, I'm just going to continue with the suction. I think this is the last little narrow section, so I'm just rotating and turning the wax plug into a different orientation to help me bring it through. Just breaking off. So in fact, probably would have been quicker using an ear hook, but hindsight's a wonderful thing. When you're doing the procedure, you feel, oh, it's on its way, it's coming out. And sometimes it can surprise you. But you can see that the entrance there is quite narrow, and we had to really squeeze that through, which we have. That gives you an idea of the curvature of the ear canal. There's a bit of opaqueness posterior to the handle malleus, but otherwise the eardrum's nice and healthy. So patient 2 has a very, very narrow entrance. In fact, the entrance of the ear canal is completely collapsed, as you can see. There's no opening there, or barely anything. So I'm having to manufacture an opening. So first of all, I'm using a fine end. With a fine end, we can somewhat squeeze through with the fine end and stretch it open, almost like a crowbar. But I'm using the instrument, the fine end suction probe, to do that. However, the fine end is just not strong enough. It's not powerful enough. So in a minute, I'm going to use a different technique. I'm going to stretch the ear open using the endoscope. So that's the endoscope going in. And on the right edge of the endoscope, I'm pushing to the right to stretch the ear canal open. That allows an opening to appear over the top of the endoscope, and then I just gently insert the suction probe over the top of the endoscope whilst the ear canal is open. So we're now using the endoscope as a crowbar. It's a bit more of a tricky technique, this. I managed to bring this through, and you can see once you're into the ear canal is quite wide. It's just the narrow section. So why is this canal narrow? There could be some edema, some swelling. Some people can have a collapsed ear canal for two reasons, actually. The cartilage can weaken as we age, and similarly to the tip of our nose, where you can develop a droopy tip. You can develop almost a droopy entrance of the ear canal because the cartilage is weakened. Another reason is the back section of the cartilage near the entrance can sometimes continue to grow, and it kind of can grow quicker than the front portion, so it almost overhangs, and therefore it loses its support, its structural support. So sometimes ENT can trim the cartilage, shorten it, so it can regain its scaffolding and its support structure. I don't think really ENT are going to be too worried unless there's a good clinical reason to widen the ear canal, i.e. the patient can't hear. So ironically, although the ear canal entrance was more or less closed, the patient, once we've got the wax out, they can hear perfectly fine, which is interesting. Or if a patient suffers from chronic ear infections, it may be another reason for ENT to consider performing what we call a meatoplasty or canaloplasty to reshape the ear canal. So it's just a wax that was hiding the front part more than I thought, actually, because of the curvature of the ear canal. It wasn't really in sight, so we're just trying to get all this little last bits out for the patient. It's quite sticky wax, just some on the roof. The eardrum's visible in the distance. The ear canal is quite inclined. Most of our ear canals, adult ear canals at least, do go up. And that's why when we examine the ear as audiologists or any hearing professional really, for adults we're taught to pull the ear back, so the external ear, the pinna, pull it back slightly and then upwards. So by pulling it back, you're straightening the ear canal from left to right, and by pulling it up, you're leveling the ear canal to take into account that upwards incline, which is about 32 degrees. There's still a little bit left at the entrance, just, again, it's almost hiding away. So I've got to get the endoscope in, stretching the ear open, and I'm going to rotate the endoscope whilst it's in situ, just so we can visualize that. I'd rather get this out for the patient because they do have to tend fairly regularly, but because of the narrow nature of the entrance of the ear canal, even a little bit of wax for them can be significant. So this in my ear, I wouldn't know, well, I probably got more wax in my ear than that comfortably, but for this patient, they probably feel it a bit more. So patient 3, it's their right ear. Again, some sticky wax, just more lateral. So this is more wet earwax. There's typically 2 types of earwax, dry earwax and wet earwax. Probably loads of subcategories under those 2 main categories. And there's a single genetic mutation that causes decides whether you have dry or wet earwax. So I'll come back to that hopefully in the course of the video. So I've managed to remove that. I'm just going to mop up near the entrance. The eardrum's nice and healthy. So there's a gene called the ABCC11 gene, and a single genetic mutation on that gene can mean that you've got a functional protein that's made by that protein or non-functional protein. So the genetic mutation is whether you have a dominant guanine allele, and if you do, that means you have a functioning ABCC11 gene that codes for a functioning protein, should I say, that is responsible for the transportation of lipid-soluble molecules into the ceruminous glands. So the ceruminous glands secrete an oily sweat called cerumen that combines with sebum, which is secreted by the sebaceous glands, and mixes in with dead skin cells and hair in the ear canal to form earwax. So if you have a single dominant guanine allele within that ABCC11 gene, it codes for a functional protein which transport these lipid-soluble molecules into the ceruminous glands. And if you don't, so if you have 2 homozygous adenine alleles, it means that the ABCC11 gene codes for a non-functional protein, which therefore doesn't transport lipid-soluble molecules within their ceruminous glands. Now, if you've got a functional protein and it transports these lipid-soluble molecules within the ceruminous glands, they join in pairs, these molecules, these different various molecules, they join in pairs. And when they do, they're either odorous immediately, or when these molecules are later secreted by the ceruminous glands, they travel up pores in the dermis layer of the skin up to the epidermis, the surface. Bacteria living on the surface of the ear canal feed off this oily sweat, and then they produce, the bacteria as a side product, they produce an odorous smell. And the addition of these lipid soluble molecules in the ceruminous glands produce a less viscosity solution, so you get more wet earwax. In the absence of these lipid soluble molecules, in the ceruminous glands. Your earwax is just more drier. You don't get the additional less viscous secretions. So that's a genetic mutation between dry and wet earwax. And if you have wet earwax, if you have a functional gene, the ABCC11 gene that codes for the protein, they are also found under your armpits. So it's more likely that you have body odor, and the body odor, or should I say more wet body odor, and the body odor is more likely to be odorous because of the odor molecules either caused by the combination of these lipid molecules which combine together, or by the bacteria themselves later feeding on these molecules when they reach the surface of the ear canal. So case 4, I didn't really talk much about, but that was more of a dry earwax, so you can see the difference. But that was a bit more dead skin as well in there. Now, if you've got dry earwax, earwax is a natural moisturizer for the ear, so it helps to moisturize and hydrate the skin. But in the absence of that cerumen, that oily sweat, you're more probably like to get dry skin. So your earwax is not only more keratin based, it's not only more skin based, but it's also drier. So as mentioned, earwax is an amalgamation of 3 primary products: dead skin cells that are exfoliated within the ear canal as they've died and shedded. Around 60% of wet earwax is dead skin, and the remaining 40% is sebum. Sebum is a lipid, oily secretion also found in our scalp. They're secreted by the sebaceous glands, and some of the compounds that form sebum is cholesterols, alcohols, squalene, long chains of saturated and unsaturated fatty acids. So they produce sebum, so it's a combination. If you've got dry earwax, then you probably got more 80% dead skin, 20% sebum and cerumen. So patient 5, that ear, just by looking at it, it looked to the previous one, it just looked a bit damp and wet in there. I suspect that patient probably had a failed irrigation or attempted to irrigate the ears themselves, so the skin was quite macerated. The wax was quite sticky and wet, but we just cleared that out for them. It's a bit tender in that. Probably I would have advised them to use some ear calm spray, some acetic acid, just to help re-acidify the ear, because if you do get water in your ear, it can wash away the natural oils. So the natural earwax that we should all have, that sits on and coats the surface of the ear canal without building up. So patient 6, it was quite deep wax here, and put some oil in there just to help lubricate it and bind it. Patient has got a bit of a narrow ear canal, so we're having to squeeze this through. So just brought it to the entrance. It's going to come out in a big plug. Quite dark wax, so it's probably been there for a while. Freshly secreted earwax is typically more of an orangey brown. You probably see that at the roof of the ear canal a moment ago. You've got some orange staining, so that's more fresh wax. But as the wax oxidizes and matures, it turns more black in appearance. So our ears should naturally recycle old earwax with new earwax. So it turns it over, and old earwax is expelled out the ear via 2 mechanisms: jaw movements. So jaw movements help wax move sideways out of the ear, but also the skin that lines the ear canal and also the outer layer of the eardrum. As that skin dies and sheds, it moves sideways out of the ear, almost like a conveyor belt. And that sideways movement is roughly 1.5 to 3 millimeters a month. Therefore, any wax sitting on the surface of that skin, that moving conveyor belt of skin, is naturally transported out the ear. So why do people develop earwax impaction? Probably one of the main causes is it's self-inflicted. A lot of people attempt to clean their own ears. So the wax is trying to come out, but the individual is pushing it further in. So whether it be with Q-tips or cotton buds, as they're called in the UK, the ends of pens or toothpicks or car keys or various objects that people have admitted to me in the past of trying to use in an attempt to clean the earwax, that's just going to push it further in. So that's one reason. The other reason could be that migration of skin that I made reference to, that conveyor belt, was either slowed down or it stopped moving. So there's no natural transportation. the conveyor belt has been stopped or slowed down, so you get a buildup of wax. Or it could be that the conveyor belt is working, but your ears are just producing a higher level and amount of wax than the norm. So you've got hyperactive sebaceous or ceremunous glands, or you have a higher turnover of dead skin. So possible reasons for higher turnover of dead skin. If you have inflammation of the ear canal, that is known to cause a higher turnover of dead skin. Or if you have skin conditions like eczema, psoriasis, you're going to have a higher turnover of dead skin. So that's one of the primary ingredients of earwax. So you just produce earwax quicker than the ear can naturally expel it. If you've got extremely bendy, twisty ear canals, the earwax, as it's trying to travel out of the ear, it gets trapped or slows down around the bends. If you think about a river, so when it's going around a bend, if I'm correct, I think the water near the bend travels at a quicker rate than the water that travels around the furthest part of the bend, and that's where it deposits big rocks, for example. It might be the other way around, but I'm sure you guys will correct me if I'm wrong. But similarly, that can happen in the ear as well. If you've got extremely hairy ears, and I'm talking extreme hair, not like a few hairs. A few hairs are good for us, actually. They help filtrate the air. It can mat against the wax as it's naturally trying to migrate out of the ear. So that's another potential reasons. People who wear hearing aids or earbuds, for example, that can inadvertently push earwax in. There are some other reasons which will come to mind. So if you've got a very narrow ear canal, so if you've got a narrow ear canal, you are going to produce wax in terms of the surface area, because although you've got a narrow ear canal, you've still got all the surface area around the canal wall, and that's where the wax is generally secreted. So that's where the ceremunous glands and the sebaceous glands are located, on the outer third, on the surface of the ear canal. So although the internal diameter is small, the surface area is greater. So narrow ear canals, you may just produce wax at a similar rate as someone with an absolutely normal sized ear canal, but because your internal diameter is less, that kind of leads to a bit excessive buildup of wax in proportionate to your ears. So of course, if you've got a smaller ear canal, and you've got someone with a slightly bigger ear canal, and your glands are secreting wax at the same rate, the smaller ear canal is going to get built up more, although proportionately there'll probably be less glands, but the surface area outweighs the internal cavity, so to speak. So that's another potential reason why. So a lot of patients who suffer Down syndrome, have Down syndrome, they are prone to getting wax buildup because they've got very narrow ear canals. They've also got very narrow eustachian tubes, which is the pressure equalizing tube which connects the middle ear to the back of the nose. And so they are more prone to middle ear infections and upper respiratory tract infections as a result. So we're on patient 9. I think I've completely missed out a couple of patients, but a lot of it's self-explanatory. So patient 9, just using a Jobson horn here. I think I was using suction before. There's a gap at the top. They've got really dry skin at the entrance, this patient. See, it's flaking away. The ear canal, it's not as bendy and twisty as some of the other patients. It's a bit straight, as you can see. The endoscope's directed into the ear canal and the eardrum is in full sight. Quite often in the case of the left ear like this, once you get the endoscope in, you have to rotate the endoscope from right to left to visualize the eardrum, because the ear canal chicanes off to the left. So I think this is probably the same patient, but it's the opposite ear. You can just tell by the entrance of the ear canal. It's very dry skin. The colour of the wax is very similar as well. So I've just put some oil in initially. I've got a feeling, I might be wrong, that I might use a Jobson horn as well. We shall see. Oh, seems like it's coming away. So the oil helps to moisturise the skin. When it's really dry skin like this, you get strong skin adhesions between the wax and the canal wall. So a bit of oil can help with that. And you can see this wax is quite dry, so the fact that the surface of the skin is very dry and flaky and the wax is quite dry as well. Probably means they have the non-functional version of the ABCC11 gene, so it doesn't code for the protein, or it codes for the protein, but that protein isn't able to transport lipid-soluble molecules that produce more wetter and more odorous wax, I should add. So they've got dry earwax. Or they've got just a bit of a skin condition, a bit of eczema at the entrance of the ear, which is possible, or psoriasis, which leads to a higher turnover of dead skin. And when you've got a higher turnover of dead skin, you naturally produce more dry wax, because the skin is, so earwax, you can think about it as having both dry and wet matter. Dry matter is the skin, and the wet matter is the oils and sweats that I made reference to earlier. So if you've got more dead skin, you're naturally going to produce more dry wax. So patient 11, this is not wax, this is a sheet of dead skin. It's going to peel that away, and behind that it's going to reveal the eardrum. So this skin in my ear, it would naturally migrate out of the ear, but unfortunately for this patient, their skin fails to fully migrate. So that skin, once upon a time, was actually the surface of the eardrum, and that skin died, it shedded off the eardrum, and it's making its way down the ear canal, but as you can see, it got trapped about 2/3 in now. I'm not sure why in that particular instance the skin got trapped, but it could have been that the patient poked in their ears, or there's a bit of an abnormal curvature of the ear canal. So patient 12, similarly, not wax, it's dead skin. Now they've got a very bendy ear canal, and it's quite elongated. So when I say elongated, our ear canals are not circular, they're oval shaped. The height should be greater than the width. I would say in this patient, of course, the height is greater than the width, but significantly more than the norm, which gives it a very oblong, stretched appearance. So patient 13, there's a bit of a gap at the top. They've got this glistening wax. Now I can tell already that this patient had been poking in their ears, because you can see the indentation in the middle. So I'm just going to get the hook over the top, rotate the hook, get some leverage. Let's see if this comes away. It looks like it is. It's going in one single piece. Got very glistening wax there. Around the perimeter of the wax plug, you may see there's a lining of dead skin, keratin, the white sheath. So that skin formerly was on the ear canal. So what's going on here? So this patient, you can tell they've got an anterior, it looks like a traumatic perforation. So it could have been that this patient was poking in their ear, and not only did they push the wax in, but the cotton bud could have gone over that top of that gap, and they might have penetrated the ear canal anteriorly at 9 o'clock and also posteriorly at around 4 o'clock. I think that's 2 perforations possibly. And that patient's ear canal wasn't quite bendy, so a cotton bud would have quite easily have gone in if you pushed it in with a little resistance. So of course it could have been completely unrelated, but it does look like a traumatic perth. But it could have been that they had a bit of a middle ear infection, and it was a secondary. So they had earwax buildup, but also they had otitis media, so fluid buildup behind the eardrum, and that built up to such a level where it then perforated through the eardrum. So that's also a potential cause. So patient 14, quite sticky, stretchy wax. You can see how it's adhering itself at 8, 9 o'clock onto the canal wall. So I'm actually going for that region there just to kind of separate it. And I'm just wriggling it. These are the ones that I found really satisfying to watch. I know people have different videos that they find satisfying, but for some reason I find these are satisfying for me. So just at 9 o'clock on the wax plug, a bit of dry skin. You can see it's more light yellow in appearance now. And there's other sections that are darker, so that's the oxidization. So that more in the core of the wax plug, it's going to be darker, and further away from the surface, so the deeper the wax, that's going to be darker because it's been there for longer. That's the patient's eardrum. You can see the short process of the hammer bone. It's very spherical. It's very round. It's pointed. No abnormality there, nothing to worry about. But yes, it is definitely a very pointed, short process of the hammer bone. So patient 15, now I think they've got 3 perforations there, 2 inferiorly, 1 posteriorly. There is some wax there. they have got a very narrow isthmus. I remember this patient. So as you approach the eardrum, there's a natural narrowing of the ear canal, probably 0.5 centimetre away. And then the ear canal widens again. It typically widens inferiorly, so the floor of the ear canal, so there's like a little ditch created. And it can also typically widen anteriorly to the front part of the ear canal, which creates the anterior recess. So this patient's got quite a prominent inferior recess. So as you approach the eardrum, that as the ear canal narrows and it widens again, it widens quite a lot. And it creates a wide basin trench, if you like. So they've got a small perforation, I think, just at 1 o'clock on the eardrum. You can see the eardrum, it's probably a bit of laryngitis there, the blood vessels are dilated. And there's 2 little perforations that may quite easily be missed if we didn't have the endoscope. For example, if I used a microscope or head loops or even the wax scope, may not have seen those 2 little ones because they're over the hill, so to speak. The thing with the endoscope, we can take the camera to the eardrum. With other visualization methods, as mentioned, ENT microscope, the wax scope, head loops, for example, the lens is outside of the ear, whereas the endoscope, the lens is inside the ear. So we can actually, with an endoscope, go closer to the object or part of the ear that we want to visualize with the endoscope, which makes the view so superior with the endoscope. It's unparalleled. The only problem with the endoscope is that and I can speak from experience, it's very difficult to train people to use an endoscope, and because you're having to use 2 hands. You're not only holding the endoscope, which is essentially the camera, but you're also having to hold the instrument in the opposite hand. So it's both hands working in tandem. And because our ears are not straight and they're bendy and twisty, you're having to use your camera hand, the endoscope hand, not only to visualize the inside of the ear, but also to manipulate the ear, to stretch it open, straighten it, get the right view. So a lot of people that have trained using an endoscope, they really struggle, and the hands are very shaky, and I appreciate it is a difficult skill. It does take practice. So someone who may not particularly be that great initially can definitely improve. When I look back at some of my videos when I first started, they were okay, completely safe, but my skill level and it's just experience, and the more you do, you get better at it. And so I still improve my own techniques. You can see those 3 holes, almost like a triangle. Just having another look. So with the endoscope, I'm trying to get over the top so we can have a really good view. So I wouldn't be able to do that with any other visualization technique, if I'm honest. And patient 16, last but not least, and I think, again, some interesting pathologies there. So they've just got dead skin here, dead keratin. We're going to peel that away. But I think from what I saw there, the eardrum is retracted, and they've got quite a prominent, what we call posterior malleolar fold. So you'll see a crease line, so to speak, from the top of the hammer bone traveling to the right section of the ear canal. So there's a horizontal fold, and we call that the posterior malleolar fold. And it's sometimes you get that, you can get an anterior one. It's when the eardrum is retracted, so sucked in because of negative middle ear pressure due to a dysfunctional eustachian tube normally. The way the eardrum, when it gets sucked in at the top, the attic region, it creates a fold over the malleus, the hammer bone. Hence the term malleolar fold. And then you can get one posterior to the malleus, and you get one to the anterior. But also, I think the scutum, which is the top part of the bone of the roof of the ear canal, as it approaches the tympanic ring, there seems some erosion there. And I think there's also some possible erosion more in the posterior superior quadrant. So when the eardrum gets sucked inwards because of negative middle ear pressure, it can sometimes wrap itself around the ossicles, the middle ear bones, and also the bone of the ear canal itself. And if it gets sucked in too much and it's tightly adhered and wrapped around the bone, it can squeeze, almost close the blood vessels that supply all the bloods and nutrients to the bone. And in the absence of all the nutrient-rich and oxygenated blood, the bone can start to decay, so we get necrosis, and it can start to separate. We call that sequestrium. So we'll have a look once we remove this skin. I think I'm going to use forceps in a minute. It's just going to lift it up and away. Very dry, thick skin. It's almost like, almost like a blanket skin. It's really strongly adhered, so just trying to get the jaws. It's quite a narrow ear, so it's difficult sometimes to use forceps in narrow ears like this, but I'm just trying to get a good grip. I'm slowly pulling it away. So yeah, they got a really prominent, and that's where the chorda tympani is. So there's a nerve that runs just behind the eardrum, adjacent to the hammer bone, called the chorda tympani, and that supplies the nerves to the anterior portion of our tongue. So it's part of the chorda tympani is also known as the nerve of taste, or one of them at least, and it helps us with the taste at the anterior section of our tongue. You can see there's retractions there, possible bone missing. Well, I hope you enjoyed that compilation video, guys. Take care and speak soon. Bye.